I'm going to talk about severe valgus knee. We already had the discussion. So this patient is 81-year-old gentleman who had a fall, had a trochanteric fracture, had a fixation with a PFN-A2. Post-op, he was unable to walk. So he was referred to me with this type of knee deformity. So bilateral valgus deformity, right side is severe. These are the supine radiographs. We can see right side he has a severe valgus with a nail in situ. Left side also he has a valgus deformity. So I did a valgus varus stress test. Valgus it is going to 25 degrees, varus it correcting to 10 degrees. This is partially correctable. There is bone loss in the femur and the tibia. And the skyline V, we can see the type 3 patella with the lateral bone-on-bone patella. These are the preoperative radiographs. Do you want to discuss or should I proceed?
Yeah. Let's stop there. Rajesh?
So I think the standard approach really, when you have a defect on the tibia like this, the medial collateral is not too stretched, and I don't think the medial collateral here is very unstable. I would do my standard tibial cut and start building up from there. The extra bone on the lateral side will be resected, the femoral cuts will be made, and then if there is a posterior capsule release is done and still there is a tightness, I would do either a pie crusting or joint line release or the IT bend. And if I, before I do that, the assessment would tell me that that's going to suffice. If the requirement is only 4 or 5 degrees, I would do that. Otherwise, the lateral epicondyle osteotomy.
Amar, would the hip status worry you?
I mean, as long as the hip healed and there's a union there, I don't think the hardware is an issue. My question was, what value did the stress views, offer you? I mean, you can do an exam and you can see if it's correctable on exam, but I don't understand why you got to do stress X-rays.
So what we call is a surgical valgus. The valgus which can be corrected with we need to correct it with the surgery. So we have an idea about how much it is getting corrected and what is the bone defect and what type of constraint you need to use. If you have a medial opening, you can document it. And generally more than 10 degrees of surgical valgus, I use a lateral arthrotomy. So I have a pre-op plan to how to go about it.
So
a little bit additional data.
You change your approach depending on the correctability of the deformity. Is that what you
Yes.
say? Yes.
For a rigid fixed valgus, I go lateral.
Okay.
And patients with the lateral patellar subluxation, I go lateral.
Okay. Right. So show us what you did over here.
So this patient, as we discussed, there is some stretching of the middle collateral ligament, which is important to understand.
So,
there is
Dhanasekara, just for the audience, how do you assess when you say stretched? At what point does it start worrying you? Is there a number? Is there a degree of opening, millimeters? How do you decide that this much is enough and I can manage with primary implants, I need something beyond that? What's your number?
So when you do a valgus stress, two things can happen. The valgus deformity can be exaggerated because of the collapse into the bone defect, or it can be exaggerated due to the stretching of the MCL. If there is a firm endpoint, I think the MCL is good. We can use a standard implant. But if it's a very soft endpoint or there is gross opening, MCL is insufficient. Yeah. That's more of a physical.
I think that's a great point because you can get this exposure or the laxity on account of two issues. One is ligament laxity and one is because of the condyle actually collapsing into the defect. Right. Yeah. Great. Yeah. So tell us what you did.
Other thing we see is the metaphyseal diaphyseal bowing. We can see both in the femoral and tibial side when you are doing a valgus knee. So you need to take it into consideration. Here the valgus correction angle was 3.5 degrees. Better to individualize for each patient. And this is a introp stress thing Amar was talking. It's partially correctable. And laterally it's opening up. The huge osteophytes. I have done a lateral arthrotomy. And I have used robotic for this patient because we have the robotic system. And it is also good to teach. I can show the gaps, how it is changing. So I used it for this case. But you can use a short intramedullary jig to use the distal femur cut. So this is a 28-degree valgus. And on varus stress, it is correcting to 11 degrees. The flexion is now 118. We can see the lateral gaps are very tight. The difference is 10 mm. So we start with the lateral release. The exposure itself, we release the IT band and the lateral capsule we release. That is the initial release we did. Then we start the planning. I'm planning to undercorrect by 3 degrees. So valgus 1 degree in the femur, valgus 1 degree in the tibia. On the lateral side, there is no bone resection as you can see on the computer. This is the tibial cut. So we check it, and then I use a sensor tensor, stretch the soft tissues to see whether there is a correction achieved. Then I do the distal femur cut. There is the resection only on the medial side. So the lateral side there is sclerosed bone. Generally you don't cement the on a process on a sclerosed bone. So I removed additional 4 mm from the lateral side. I use a distal femur augment on the lateral side. I'm using a PS type of processes. This is the alignment, and we can see there is 2 mm difference in flexion and extension. But the problem is there is a mid-flexion laxity. As we flex, you can see there is a mid-flexion laxity. So for this, I need to lengthen the lateral side and stretch the posterior capsule. For that, I opted for a lateral epicondyle osteotomy. This is you can see that attachment of the lateral collateral ligament. So distal to the lateral collateral ligament attachment, we can remove the bone and then slide it down and release the posterior capsule to get the extension gap better. So I used from 5, I moved to 10 mm insert. Now the difference is only 2 mm. This is the final alignment correction. I use a lateral augment and fixation for the lateral epicondyle osteotomy. Post-op, we keep the knee in flexion for 24 to 48 hours. This is the 1 month follow-up X-ray.
Then,
Yeah, please go ahead.
then do you think in this case you would have rather gone laterally? Because from what all you described, would have been better seen laterally.
Better?
You went laterally, sorry.
Yes, I went lateral. Yes. So just a few more take-home points. Dr. Ashok showed this.
Ashok, can I?
Yeah,
Yes.
sure.
You know, I think the point I was making that when you have a lateral tibial condyle defect like this, the medial collateral does not stretch beyond that. And
Yeah.
he's used a standard implant here.
Yeah.
That medial collateral to me did not appear stretched, and a standard implant sufficed.
You're exactly right. The deformity was on account of the condyle actually collapsing into the defect on the tibial side. Yeah.
So for a type 1 correctable valgus, Amar and Ranawat has described inside-out technique, posterior capsulotomy and IT band pike resting. So it is can be done with the standard processes. For a type 2 partially correctable valgus, you can do a sliding osteotomy, which we have published our experience of 28 patients. Or we can do a slightly constrained implant like this, a TC3 or LCCK. Metaphyseal diaphyseal remodeling, again Dr. Amar and Ranawat has published. We have published our experience in Journal of Orthopaedic Surgery. You need to have a more medial reference when you're using an extramedullary jig. So your alignment of the tibial component is perfectly placed. And lateral retinocular release, it might be necessary in subluxed knees. This also we published in Indian Journal of Orthopaedics. And we already discussed severe valgus, post-HTO, we use a hinge type of processes. And severe stiff valgus, we have our experience of common peroneal nerve release. We do a isolated lateral incision, release the peroneal nerve from the fibroosseous tunnel around the fibula and avoids the lateral peroneal palsy. Bone loss has to be managed. Sequential release is helpful, and use of constrained process may be useful in severe valgus deformity. Thank you.